Sir, please unmute yourself. Sir, please unmute.
Am I audible?
Yes, sir.
Thank you. Thank you, Garima. I have the privilege to introduce two stalwarts in field of gynecology and my wonderful friends from Germany, Professor Rudy Leon de Wilde and Professor Hugo Verhoeven from Germany. Our cooperation and friendship goes way beyond 22 years, and I have learned many things from them. Apart from an excellent surgeon, Dr. Rudy has excellent leadership qualities, and Dr. Hugo is a very humble and always joyous personality. You'll able to see yourself with an excellent academic contribution. I'm grateful to both of them to be part of our Congress, and thank you very much for being here with us. Dr. Rudy Leon de Wilde is a past president of European Society for Gynaecological Endoscopy. He is a director of ESGE and responsible for dissemination of knowledge in minimal invasive surgery and setting up minimal invasive surgical training centers all around the world. He is professor and he is at the University Hospital for Gynaecological Oncology, Pius Hospital, Oldenburg, University of Oldenburg, Germany. He's a great human being, and you will witness him tonight. Dr. Hugo, as I described, humble and joyous person, and with a good academic
Hello, Sangpal sir, can you hear us?
We've lost Dr. Sangpal, but I think I can take over this amazing task of introducing Dr. Hugo. He's been a friend of India's for a long time. And like Dr. Sangpal was saying, he's a medical director at the Private Center for Endocrinology from Germany, Düsseldorf. And he's a senior consultant at the Carlyle Investment Company as well.
Yes.
And he's a champion of the European Society for Gynaecological Endoscopy working group on non-surgical ablative therapy of uterine disease. So we look forward to seeing their presentation and of course interacting with them later on and also at the end of the CME today at around 8 o'clock. So let's go ahead and see the presentation.
Dear colleagues, dear friends, I'm Hugo Verhoeven, the medical director of the Private Institute for Endocrinology, Reproductive and Preventive Medicine in Düsseldorf, Germany. The topic of this webinar will be non-surgical ablative therapy of adenomyosis. I bring you the greetings of the ESGE working group on non-surgical ablative therapy of benign uterine disease. I'm at the moment the chairman of this ESGE working group. And I bring you also the greetings of the European Academy of Gynaecological Surgery. As said before, topic of this webinar is adenomyosis, therapy and diagnostic. So adenomyosis is also called endometriosis interna. This in contrast with the so-called endometriosis externa. So adenomyosis is endometriosis within the uterine wall. Endometriosis externa is endometriosis outside of the uterus. This disease is unknown to most of the patients, especially the infertility patients. But the disease is also unknown to most of the medical professionals, especially the reproductive endocrinologists and endoscopic surgeons. The medical treatments as well as the endoscopic treatments, laparoscopy or hysteroscopy, are not very convincing, so that we have never been very happy with the treatment possibility of adenomyosis. Of course, alternative treatment options came on the market, like HIFU, but unfortunately interest was very limited. Before we go on with this webinar, I would invite you to have a look at this paper of Silvia Vannuccini, Recent Advances in Understanding and Managing Adenomyosis, what will give you a very nice overview of what is known nowadays of adenomyosis. Let me start with this beautiful picture. About 1.5 years ago, I was invited to a meeting on HIFU in Chongqing, China, and I had the pleasure to sit next to 3 of my very old friends. On the right side, you see Professor Shilong Li from Taiwan. At the moment, he is the APAGE president. Next to him is Professor Felix Wong from Hong Kong, and next to him is Professor Keen Wai Lee of Singapore. Those 3 professors convinced me 1.5 years ago to have a look at the very new treatment possibility for myomas and adenomyosis. As I said before, we were till now always very unhappy with the treatment possibilities of adenomyosis. So those 3 guys said, Hugo, just have a look at it. And from that moment, I was convinced that we had something new. So I went to Chongqing several times and learned the technique of HIFU. As said before, adenomyosis is also called endometriosis interna. Adenomyosis is a benign uterine disorder in which endometrial glands and stroma are pathologically demonstrated in the uterine myometrium. Women affected by adenomyosis may present abnormal uterine bleeding, dysmenorrhea, dyspareunia, infertility, but 1/3 of those patients are asymptomatic. Over the last decades, adenomyosis has become a condition identified in very young fertility age women thanks to the recent advancements in imaging techniques. If we want to have an overview of the pathogenesis of adenomyosis, there are 3 theories. Number 1 is the invagination of basalis endometrium into the myometrium through an altered or interrupted junctional zone. Number 2 would be that the disease arises de novo from metaplasia of embryonic or adult stem cells into the myometrium. And the 3rd hypothesis would be that after retrograde menstruation, ectopic endometrial cells have the potential to infiltrate not only pelvic organs, causing endometriosis externa, but also the uterine wall, causing endometriosis interna. About definition and diagnosis of adenomyosis, first of all, histology. Till a few years ago, the gold standard to make the final diagnosis of adenomyosis was the histological examination of hysterectomy specimens. But of course, in our infertility patients, we have no hysterectomy specimens. So in those patients, it is very difficult to have a clear histological examination of your suspected tissue. That means that in infertility patients, Imaging techniques such as MRI and transvaginal ultrasounds are the only possibility to make a correct diagnosis of adenomyosis. Let's talk first about transvaginal ultrasounds. This is certainly the first-line imaging technique to diagnose adenomyosis. It is widely available, inexpensive, and quite accurate if performed by expert sonographers. And this is, of course, one of the problems. Many of gynecologists and even reproductive endocrinologists are not expert sonographers. So that means transvaginal ultrasound is certainly a very good step. But as we all know, the uterine wall has not only two layers, the myometrium and the endometrium. There is a third layer called the junctional zone, and the junctional zone is not seen on a transvaginal ultrasound sonography. That means that for an adequate diagnosis of adenomyosis, we need to use magnetic resonance imaging. This technique makes it possible to evaluate the junctional zone and also the myometrium. We have no time here now to discuss more the function of the junctional zone, but it seems to be critical in the uterine wall for implantation and also for placentation. On this picture, you see very clearly three layers. We see the myometrium, we see the endometrium, and between the two layers we have a black zone called the junctional zone. This can only be seen with MRI. Of course, adenomyosis is not a single finding. Most of the patients have, besides of adenomyosis, also endometriosis and uterine fibroids. As said before, we are not interested in postmenopausal patients with adenomyosis. We are interested in our fertility patients. Okay, it is very difficult to find out exactly what the impact of adenomyosis is on fertility. So I advise you to have a look at this publication of Sebastiano Campo called Adenomyosis and Infertility. For the management of adenomyosis, as said before, we have, of course, the surgical approach, whether we do it hysteroscopically or laparoscopically. Unfortunately, both techniques are for adenomyosis not very successful. We have the hormonal or medical treatments, but also this management of adenomyosis is not very successful and has a lot of side effects. If we want to do a correct evaluation of the uterine wall, we have three possibilities. On the left side, you see MRI with clear visualization of the myometrium, the endometrium, and the junctional zone. We have also ultrasound, 3D ultrasounds, where we see also very clearly the endometrium and the myometrium. The junctional zone cannot be seen. And then, of course, the hysteroscopic image, where we see only the internal part of the uterus. As said before, MRI gave us a complete new image of the uterine wall, So for the first time, we saw on MRI that there is a third layer in the uterine wall called the junctional zone. And as you see in the upper image, we see number 1 endometrium, 2 junctional zone, 3 endometrium, and the images under the first one, you see that the junctional zone is not normal. There are very evident alterations of the junctional zone. But, as said before, all hysteroscopic and laparoscopic treatments of adenomyosis are not very convincing. So I go back to the advice of Professor Lee, Professor Wang, and Professor Shilong Lee to have a look at a new technique called HIFU. We are talking here on the ultrasound-guided HIFU and not of the MRI HIFU. The difference is, of course, that MRI HIFU can only be done by the radiologist in a special room, and the ultrasound-guided HIFU is possible, as I show you immediately, in a very normal room, and every gynecologist can do that. Before we start thinking about HIFU, we need to know that before we are starting to perform HIFU, we need to have a perfect knowledge of MRI, ultrasound, real-time ultrasounds, of the anatomy, of the different HIFU techniques, and the most important is, of course, the interpretation of the HIFU procedure, the interpretation of what you see. As said before, ultrasound-guided HIFU can be done in a normal room. So you do not need a OR, you do not need the radiologist. Every gynecologist or urologist or neurologist or oncologist can use this technique without that we need the help of the radiologist. This picture you saw already before. Very important is that the treating doctors are on one side of the room and are performing the complete procedure online. This has also the advantage, if you're getting into trouble or you need the advice of more experienced persons, you can always be in contact with them and they can give you advice and even take over the procedure. The patient is on the left side. As you can see, she's laying on her belly. The procedure takes about 1 to 2 hours. The patient is in conscious sedation. She cannot be in a deeper anesthesia because we are depending on the reactions and the comments of the patients. Indeed, if skin burns or eventual lesion of nerves, the patient will tell you that, and we know then that we need to be active to avoid complications. So let's have a look at this video.
An ultrasound beam can be brought to a tight focus at a distance from its source, with sufficient energy concentrated within the focus. The cells lying within will be killed without damaging the surrounding tissues. High-intensity focus ultrasound, HIFU, is, therefore, a non-invasive method of producing selective and trackless destruction of deeply seated tissue targets within the body, without causing any damage to the overlying surrounding tissues. Ultrasound-guided HIFU involves HIFU ablation under the guidance of real-time ultrasound imaging, which can achieve an uninterrupted visualization of tissue coagulative necrosis during the treatment via grayscale changes in real time. The ablated lesions demonstrate an echogenicity or grayscale changes in the ultrasound images after the sonication, which enables immediate assessment of patient's response to ablation, ensuring a safer and more controllable therapy. Imaging fusion and three-dimension digital reconstruction function provide doctors with a much clearer vision during the whole procedure. Thus, doctors can finish the treatment with an ease. Ultrasound-guided HIFU, a new option for the gynecologist to manage uterine fibroids and other gynecological benign tumors, can maximally preserving the integrity of the uterus. No surgery, no bleeding, and no anesthesia. Patients can even chat with doctors during treatment to ease their tension. Patients can go home in merely 2 hours after the treatment and resume normal life the second day after treatment. Post-operative MRI may still detect the presence of ablated lesions. However, vascularity is now absent in the ablated region.
I think this was a very nice video to demonstrate the technique of HIFU. As we know, if we are treating myomas, we can do that with laparotomy, with laparoscopy, causing scarring, bleeding. With HIFU, we have no scarring at all. As seen before, conventional surgery produces scars, laparoscopic procedures also. HIFU produces no scars at all. Once again, my presentation with one of my first cases. You see here also a patient with a diffuse adenomyosis. For me, at the beginning, it was always the most important thing to visualize. If we look at the MRI image, you can clearly see the adenomyosis. On ultrasound, it's not that easy at the beginning. So you need to visualize exactly where the lesion is. And as soon as that is done, the computer will take over completely, will make slices and decides with what doses and how many slices will be coagulated. So this patient was done after 50 minutes. Important is after the procedure that we check the skin of the patient, whether there is a burn of the skin, what the patient will most of the time tell you, but sometimes she will tell you only the day after. And you see that after 1 hour, the patient is leaving the normal room, going to a room, and the next day she's leaving the hospital. She can even leave already the same day. But as the patient needs to travel quite far, it is better that she stays another day. So this is the image of the patient 1 day after the HIFU treatments. We see very clearly the coagulated region. I thank you very much, and I hope you enjoyed my webinar, and I hope to welcome you in the near future for another webinar on another topic. Thank you very much.